Okay, injections and venipuncture. These are kind of cool things to know. You won't necessarily be doing things right off the bat, but after assistants get good, the next step is to like learn how to do these. But these are just nice to know as a kind of like why we do these things. So injections, right? There's multiple places that we can give injections to, like multiple sites of injection. So each site has like a pro and a con for each and a duration of action. And certain drugs can only be given in certain sites. So there's certain drugs that can only go sub-Q. There are certain drugs that can only go IV. There are certain drugs that can only go IM. And there are certain drugs that can go all three ways or maybe just two. Also in this realm of injection and venipuncture, we're going to talk about blood collection and IV catheter placement. All these things take lots of practice, but the more that you watch people do, and then you'll get exposure to them, and then eventually have to get a little shot at trying them out for yourself. So sub-Q injections. This is a subcutaneous injection. It's given into the skin. So a perfect example of an injection that's given into the skin is vaccines. A vaccine is a sub-Q injection. So sub-Q injections, as far as duration of action go, they last the longest. They're the longest lasting of the injections, but their length of duration depends on the drug. So some drugs last up to 1 week given sub-Q. Some last only 4 hours. And then in the case of vaccines, that's like a year to 3 years because of how immunity works. But also, even though they last the longest out of all the injectable sites, they're the slowest acting. So if we were given something like anti-nausea medication or pain medication and we give it sub-Q, it's going to take quite a while for it to act. Usually about 30 minutes before it'll kick in. So yes, it takes longer to take effect, but it hangs on board a lot longer too. When it comes to cats and sub-Q injections, you only want to give sub-Q injections in cats on the skin of their limbs. You never want to give a sub-Q injection to a cat on their shoulder or on their flank, because cats get something called injection site sarcomas. At first, it was just believed that this was from vaccines, like a vaccine site sarcoma, but new research has come out that says that this is any injection can cause an injection site sarcoma. What sarcoma is, it's a skin cancer. So it's a cancer on cats that they get just from getting injections of any kind. So the reason that we always want to inject on the leg in cats is that if a cat gets a sub-Q injection site reaction, an injection site sarcoma, the limb can be removed and the cancer removed. If the injection site sarcoma happens on a shoulder blade or on a flank or on their side, it can't be removed. So it's the quality of life and prognosis for that patient is much poorer if it can't be removed. So that's why we always do sub-Q injections on limbs. So that way, once the cancer pops up, we can just take that whole leg off. So how do you give a sub-Q injection? So sub-Q injections are the simplest of the injections. So what you're going to do is you just grab a little bit of skin and you make almost like a tent. And then you insert the needle at the base of the skin tent, and your needle is parallel to your patient. So you're not stabbing downward, you're going along the body of the patient. You insert your needle and then you pull back slightly on the plunger, because even though we're not trying to hit a vein, there are vessels in the skin. So sometimes we could be giving a sub-Q injection and then by the grace of whoever, accidentally be in a vessel. So you always want to pull back on the plunger a little bit to make sure that you're not in a vein, because remember, there are certain drugs that can only be given sub-Q and cannot be given IV. It's detrimental if it's given IV. So you pull back that plunger, make sure there's no blood, and then you can depress the plunger into the skin and administer the drug. Then you pull that needle out, and then I always massage the injection site. It helps facilitate drug distribution, and also it feels good. So IM injections, these are intramuscular injections. These are injections that are given into the muscle, usually the semi-membranous muscle in the rear leg, or on the lumbar muscle, so the muscles in the back. You'll usually see this in heartworm treatment patients. They get it in their lumbar region. So this is the intermediate reacting acting drug. So it's kind of rapidly, I mean, within like 5 to 10 minutes, it takes effect, and it has like a shorter duration of action, much shorter than like a sub-Q would. So I mean, maximum IM, you're talking like maybe 4 hours that the injection is working. This is only used for small volumes of drugs, so we're not pushing like 10 mils into the muscle. Like, only tiny volumes of drugs go into the muscle. And when you're injecting into the muscle, especially in the back leg, you want to avoid the sciatic nerve. The sciatic nerve is a huge nerve that comes off the lumbar plexus that runs down the side of the leg. It's a big, massive nerve, and you don't want to damage it. So here are some pictures of the first one is the nice meaty booty of that back leg, and then the second one is the lower lumbar muscles of the back. So you want to hold that muscle between your fingers. You want to get a good grip on it. You want to be able to palpate that muscle, and then you insert the needle perpendicular to the muscle. So when we're talking about sub-Q, we're going alongside the body. For IM, we're going directly into the body. So like bloop, like stabbing it right in there. So once your needle enters the muscle, same deal. You want to pull back on and aspirate that syringe before you administer to make sure you're not in a vessel. Then depress the plunger, and then massage that injection site for drug distribution. So this is the image of a skinless dog post-mortem to kind of give you an idea of where the sciatic nerve is. So the sciatic nerve is in dogs, it's on the lateral side of their leg. So that's why when we're giving an injection into the leg, we want to come from the back of the leg and not the side of the leg, because we want to avoid that sciatic nerve, because it is very excruciatingly painful if it's touched, and it can do serious, permanent, lifelong damage if it is stabbed with a needle. So you always want to come from the back side of the leg, never the side. IV injections. So this is intravenous injections. These are drugs that are given directly into the vein, and it is very, very rapid. Their duration of action, their onset of action is very rapid. I'm talking like the second that you're finished pushing the drug, whatever drug you're giving, the effects are already on board. This is really evident when you're like pushing things like propofol for sedation. Like you're giving a sedative IV and they are immediately asleep, but before you can even pull the needle out of their vein. But even though this drug is the quickest to work, it also wears off very, very, very quickly. The most common veins that are used for this drug are the cephalic, which is the front leg, or the saphenous, which is the back leg. And only certain drugs can go IV. This is incredibly important. If we make a boo-boo and accidentally give a drug sub-Q that's not supposed to go to sub-Q, we could cause damage to the skin. Same with the muscle. We can cause tissue damage if we put something that's not supposed to go in the skin or the muscle. But if we put something in the vein that is not supposed to go in the vein, we could immediately kill that patient. I'm talking, before you pull the needle out, your patient could die, because this drug reacts so quickly. This drug acts so quickly. So when we put things in a vein, we need to make absolutely certain that that route of administration is correct. That when we're being asked to put something IV, that it really truly goes IV, because we could potentially kill something. A good little red flag to know is that all IV drugs are clear. They all are clear. There is only one drug on the planet that you can be given IV that is not clear, and that's propofol. It's white. That's the drug that killed Michael Jackson, by the way. He calls it his milk because it looks like milk. It's a white, milky substance. That's the only not clear drug that will go in a vein. So if somebody hands you a drug that's not clear and asks you to put it IV, that's an immediate red flag that route of administration is incorrect. So administering IV injections. So whenever you're going into a vein, you always want to start as low as possible on the limb so that if the vein blows, you can just move your way up the leg. Because if you start really high, you can't go any higher. For venipuncture or for IV injection, your patient's going to be held with like the head hug and the vein rolled off just like usual for any other kind of blood draw. And you're going to alcohol your patient's limb. You're going to insert the needle parallel to your patient into the vein. And you're going to pull back on that plunger. And you want to get blood back in that syringe because that confirms that you're in a vessel. Once you know that you got blood in that syringe, your restrainer can let off, and then you can just slowly push your drug. And then you can pull that needle out and hold off that vein to make sure it doesn't blow. But IV injections, just like blood draws, these are really take finesse and skill to learn. It is very easy to give a sub-Q injection. It takes a little bit of practice to get a good IM injection, but to hit a vein, it takes practice. You're going to miss a lot of veins before you hit a lot of veins. So there are a couple of other injection sites that are not used as commonly. So intradermal, that's ID. So it's given in the dermis. You may have experience with this if you've ever gotten a TB test. So that test that your doctor gives where he injects things like right underneath your skin and the little bumps pop up. And they use a little card to tell if you're positive or negative. That's an intradermal injection. You'll usually see it in like dermatology departments of veterinary medicine where they do like things like skin testing and allergy testing. You really won't see it in this hospital, but it's good to know if you ever move on. All right, IO, that's intraosseous. So that is given directly into the bone marrow, and this is usually used in like neonatal patients when you can't get a vein. So like little baby kittens and little baby puppies whose veins are, you just can't find them. You can put like a catheter needle in the head of a femur and inject medications from there. Intraperitoneal, so this is IP. These are drugs given in the abdominal cavity. So sometimes this is what's used to euthanize patients. If a vein can't be hit, but it's kind of slow duration of action, and the patient has got to be under anesthesia because it's very painful. I really don't understand why intraperitoneal is really ever used, because there is a much better method, and that would be this next one, the intracardiac. So intracardiac is just like the intraperitoneal into the stomach, but this is into the heart. So intracardiac goes into the heart, and it is also used the same deal when you are trying to euthanize something and you can't hit a vein. But the beauty of the IC stick is that after you inject it into the heart, it is immediate and instantaneous. It is not long or slow. It is not a long, slow process like intraperitoneal is. But this also must be given when the patient is under general anesthesia. Being stabbed in the heart probably really sucks. So you want your patient completely anesthetized before you would ever do an intracardiac stick. But again, this is like last resort. You can't find a vein. Give your patient IM sedation, let them go under anesthesia, put a mask on them, let them breathe ISO, and then when you know they're out, then you go ahead, enter your needle into the heart, draw back, get blood in your syringe, and inject. So we briefly talked about this earlier about blood collection. So you got three main sites: cephalic on the front leg, saphenous on the back leg, and jugular in the neck. Again, jugular, biggest, fastest vein to use, is lovely if you need high volumes of blood. Saphenous vein, that's the back leg, is best to use in fractious animals so you're not in their face. And cephalic, if you're getting blood from a sick patient that you think is going to need to be hospitalized or be transferred somewhere, avoid the cephalic vein. You want to save that cephalic vein for an IV catheter if you think that this patient is ill enough that it needs to be hospitalized. Also, whenever you pull blood, when you're looking at your needle, every needle has a little bevel, and you want that bevel side up. I will show you a picture. I don't know why I have not included a damn picture in this thing, but we'll talk. I'll show you what I'm talking about. So jugular vein is the go-to if you need a large collection of blood. I'm not talking about for a heartworm test. For a heartworm test, all you need is like 3 mils. But if you need to send something out like a CBC or a chem, or you're running something in-house like a CBC or a chem, your jugular is your best bet. It's the quickest, fastest vein. However, it takes the most practice out of all the veins to hit, because you really can't see the jugular vein with your eyeballs. This is something that you have to feel and palpate. And in order to get good and learn anatomy and feel, it takes a long time. It takes a lot of practice to get good at a jug. And like I mentioned earlier, don't ever pull from the jug if you got thrombocytopenia or rat poison or some other kind of clotting disorder, because that jug is so big and that's such a big vessel that if your patient, if he can't clot blood, you could really do damage, and he will bleed for a long time from that jugular vein. So field your patients before you start sticking in a jug. So the way to hit a jug is your restrainer will be holding your patient and extending that neck, and you are actually going to occlude the vein yourself. So you press into the thoracic inlet, which is right on the inside of like their collarbone, basically, their clavicle. Well, dogs don't have clavicles, but like right at the base of their neck, there's a thoracic inlet that you'll be able to feel, and you press down on both of them, and then squirt a little bit of alcohol and lightly feel around the neck. So a trick is, if you've ever looked at a dog, in fact, if there's a dog near you or around you, or the next time you look at a dog, I want you to look at a dog head on, and you will notice that on the sides of their neck, they have like a line of fur that goes down where, like, it's almost like a tiny baby cowlick where the two fur ends meet, and it creates two little lines. That is typically where the jugular is. Also, you can make a invisible line from the outer corner of their eye and draw that line all the way down, and where that line comes down is typically where the area you will find the jug. This is not true for every patient. Some patients have a very medial jug, some patients have a very crazy lateral jug, but typically it's in that area. Draw a line from the outer corner of the eye all the way down to the neck. Your jug's generally in that area, or look for where the hair meets. All right, so cephalic and saphenous. So this is very similar to how you would give an IV injection in the cephalic and the saphenous. So same deal. You're going to go parallel with the patient. You're going to have a restrainer that's holding off the vessel. You're going to draw back on your syringe, and you're going to collect your blood. So IV catheters, placing them takes a lot of practice and finesse and skill. This is not like a one and done, I did it kind of a thing, because there's many parts to placing an IV catheter. So what an IV catheter is it is a little synthetic polymer tube that gets inserted into a vein and is indwelling. So it stays there. It's taped in, so there is easy IV access to a patient. So typically, sick patients that need IV fluids and IV medications will have IV catheters, and patients that go under anesthesia will have IV catheters. The reasoning for this is that if a patient starts to become compromised on the table, or if they completely go into cardiac arrest, then rescue drugs can be given immediately in the vein, because remember, as we learned, IV injections are the quickest duration of action, and when you're dying, you have, seconds matter. So you can't be given a rescue drug sub-Q or IM. Say goodbye to your patient. But those are the primary reasons for having IV catheters: anesthesia and illness. So a catheter is actually made of two pieces. So that polymer, that synthetic polymer plastic, Teflon, whatever it's made out of. Different companies use different things. That is indwelling into the vein, and the needle that helps you get it into the vein. So when you insert a catheter, you're inserting both a needle and the actual polymer, which is the catheter. It goes into the vein, and then once it's seated into the vein, that needle gets pulled out and just the plastic piece remains in. So you don't have a sharp, hard needle stuck in your arm for days. After the catheter is placed, it is then taped in, and not only is getting a catheter in a vessel technically skillful and needing of practice, but taping a catheter can be very complicated and confusing for people, and it takes a lot of practice. This is something that it'll probably take you about 25 times to do before you're even remotely confident that you can get it right. This is just a play-by-play of how to place a catheter and how to tape it. Now, there are a bajillion ways that people tape in their catheter. The way that I listed here is the way that I tape it because it uses the least amount of tape. And I just find it holds catheters in legs amazingly. I'm not going to go through all these steps because this is something that really needs complete visuals along with these instructions, but these are good to read over and kind of learn in your head. So that way when it comes time to you actually learning, that you've kind of read this over and you have a little bit of a general sense of what's going on when it comes to placing an indwelling IV catheter.